30% of all wounds are categorized as non-healing, yet these wounds make up 67% of the cost of wound care. And as wound occurrence is on the rise, 71% measured between 2013 and 2018, still a quarter of wounds lack a differential diagnosis, hampering the delivery of proper care. In this Smith+Nephew video, we're going to take a look at chronic and non-healing wounds. We'll see what chronic and non-healing wounds are, why some fail to heal as expected, and how to properly assess and treat them using current best practices. Let's get started. Chronic and non-healing wounds. First, let's look at the difference between a chronic wound and a non-healing wound. Chronic wound is a wound that fails to progress through the normal stages of healing in the expected time frame. This time frame is typically about 4 to 6 weeks, and these wounds tend to stall out in the inflammatory stage. But non-healing is a more general term, used to describe any wound that is not showing expected signs of healing within a 4-week time frame. So these could be wounds that are coming up to being 4 weeks old, but are not showing the normal signs of healing. In this case, they have not yet been classified as chronic, but their lack of healing should still alert clinicians that an intervention is needed. The 4 stages of wound healing. Let's take a quick look at what normal wound healing looks like. This occurs in 4 stages, but keep in mind that this is not a neat and tidy process and that these stages will overlap. The first stage is hemostasis. This happens immediately after an injury. Blood vessels become narrowed and platelets clump together to stop the bleeding and form a clot. This stage can last up to 24 hours. Next is the inflammatory stage. Here, white blood cells arrive in the wound to clean up debris and fight infection. This naturally creates some inflammation characterized by redness, swelling, and heat. This stage starts within hours and peaks within 1 to 3 days. Then comes the proliferation stage. In this stage, new tissue starts to form. You'll see pink granulation tissue growing in the wound bed and new epithelial tissue growing around the edges, eventually closing the wound. This stage starts around day 3 and can last for weeks. Last is the maturation stage. This is where the closed tissue reorganizes itself, creating a stronger and more flexible matrix. This begins around week 3 and can continue for months or even years. But why do these wounds fail to heal? There are 2 main factors we can look at: patient-related and wound-related factors. Patient-related factors. These include factors that directly affect the overall health of the patient. Things like comorbidities that reduce their capacity to heal. These include issues like vascular conditions, such as peripheral arterial disease, PAD, and chronic venous insufficiency, CVI. Also, other conditions like diabetes or immunosuppression and obesity. Nutrient deficiencies can also hinder cell repair, such as protein deficiencies, deficiencies in vitamin A and C, and zinc. And finally, there are other lifestyle factors like increased stress or smoking. All these things can greatly hinder wound healing. Wound-related factors. Now let's look at factors in and around the wound that can prevent healing. There are many factors that you can't do much about, things like location on the body, size, or how long the patient has had the wound. But we'll focus on some factors that can be addressed by the right choice of treatment. The first almost goes without saying. Repeated physical trauma to the wound can put you back at square one. But one of the greatest hindrances to healing is biofilm and infection. Biofilm creates a home for bacteria that allows it to stick to the wound and protects it from the body's immune response. It even protects it from antibiotics and antimicrobials. This keeps the wound in a low-grade inflammatory state. But infection is also a great concern as it damages tissue and the wound cannot heal until it is dealt with. But as impactful as foreign bacteria can be, the body's own internal inflammatory response can be just as concerning. This brings us to our next factor, prolonged inflammation. First, immune cells arrive in the wound to clean up debris and fight bacteria. During this process, they release enzymes called proteases. At first, these proteases are helpful because they dissolve dead tissue. But if this process goes on too long, the proteases build up and start to damage healthy tissue. Immune cells also release another substance called ROS, or reactive oxygen species. This is an oxidizing agent used to kill bacteria. But as before, in unregulated quantities, ROS can also damage healthy tissue. And what can make matters worse is that as immune cells fight bacteria, they give off a kind of SOS signal in the form of cytokines. This calls more of them to the site, exacerbating the problem. As the fight goes on, the body tries to flush the debris and inflammatory mediators with exudate. But this makes the exudate itself high in inflammatory mediators. It's basically a failure to shift from pro-inflammatory to anti-inflammatory signaling that can be a main factor in stalled healing. The next wound factor that hinders healing is poor vascular perfusion. Patients with reduced blood flow can have low oxygen levels in the tissues. This impairs processes that rebuild tissue like ATP production and collagen synthesis. This kind of hypoxia also disrupts fibroblast and keratinocyte function. Poor perfusion can also be caused by a number of reasons like vascular disease, like PAD, anemia, or a type of swelling in the tissue caused by edema. Besides these main causes, another interesting factor that we'll take a quick look at is the presence of senescent cells, sometimes called zombie cells. These are cells that undergo immense stress during prolonged inflammation and become dysfunctional. They cease to multiply or do so very slowly, but they do not die. Instead, they just contribute to inflammation and also impair the production of extracellular matrix, re-epithelialization, and angiogenesis. Now, let's look at how we assess and treat non-healing wounds. The first step is identifying non-healing wounds early and properly escalating your treatment plan. The longer a wound remains unhealed, the more complex it becomes and the longer it will take to heal. For most wounds, the size should reduce by about 40% over a 4-week period. But a tool like the Bates-Jensen Wound Assessment Tool can be more helpful in noticing the subtle signs of wound healing, stagnation, or deterioration. As the wound progresses or fails to progress, use the Wounds UK 2022 Best Practice Statement flowchart to know when and how to escalate. First, start with standard therapies. These therapies rely on the body's normal healing process to heal the wound. These include cleansing, using sharp or hydrolytic debridement, and applying standard wound dressings. If the wound is not advancing like normal, switch to active therapies. These take an advanced approach, augmenting or supplementing the body's natural processes. These can include antimicrobial dressings, negative pressure wound therapy, hyperbaric and topical oxygen therapy, enzymatic debriders, and others. Finally, if active treatments fail to move the wound towards healing, refer the patient to a specialist, such as a wound care team, vascular or infectious disease specialists, dermatologists, or plastic surgeons. Timers. You may have seen the time assessment tool. This is valuable in guiding clinicians in addressing local wound factors. However, when we're managing non-healing wounds, we recommend using its successor, the Timers framework. Timers offers a broader, more holistic perspective that includes systemic and psychological factors critical for successful wound healing. We'll start with the T of Timers, which stands for tissue type. Here, we inspect the tissue to see how viable it is. We want to see healthy, pink granulation tissue. We don't want to see necrotic tissue like slough or eschar. Standard treatments call for cleansing the wound bed and debriding using sharp or hydrolytic debridement. When escalating to active treatments, use larval debridement or enzymatic debridement if it is available in your location. And if you need to refer the patient on for tissue issues, refer them to a tissue viability nurse or specialist. Next, the I in Timers stands for inflammation and infection. As we saw before, inflammation and infection play major roles in preventing wounds from healing. If a wound is in the inflammatory stage of wound healing, it's natural to see some inflammation. You should see erythema, a reddening or darkening of the skin that extends no more than 2 centimeters beyond the wound edge. This inflammation should start to subside after 3 days, and you should see no signs of systemic infection. Standard treatments for inflammation include debriding the wound. In the last section, we debrided in order to clear away non-viable tissue, but debridement is just as crucial when fighting inflammation and infection. Debridement is your first line of defense, as it can return a chronic wound bed to something more like an acute wound bed. For an active treatment of inflammation, you can consider an MMP inhibitor, as this can help neutralize inflammatory substances. And if you need to refer your patient for chronic inflammation, consider a wound care specialist. But biofilm and infection are also closely tied to inflammation. Now, you won't be able to spot biofilm directly, but biofilms are present in most chronic wounds. Here are some indicators that can clue you in to their presence. If the wound is at least 4 weeks old, there is resistant to treatments with antibiotics or antiseptics, if you see low-level chronic inflammation and delayed healing, or excessive moisture or exudate. On the other hand, if an active infection starts to set in, then you should see erythema that extends beyond 2 centimeters of the wound edge, warmth, malodor, and purulent exudate. And signs of a spreading systemic infection will include fever or low body temperature, chills, rapid heart rate, rapid breathing, and potential confusion or disorientation. As far as standard treatments go, debridement is your go-to, as it will disrupt biofilm, making the bacteria inside vulnerable to antimicrobials. But if you do see infection, make sure and include active treatments from the start. Use topical antimicrobials or antimicrobial dressings along with your debridement. Cadexamer iodine, silver, and honey are common antimicrobials. Use systemic antibiotics for spreading and systemic infection only. And once infection has been treated, negative pressure wound therapy, or NPWT, can be helpful in protecting the wound from foreign bacteria. And if you need to refer, consider an infectious disease specialist. Now, let's move on to the M in timers, which stands for moisture balance. You should see a moist but not a wet wound, as wounds need a moist environment to heal. But exudate is high in proteolytic enzymes and free radicals, so too much of it can be harmful. Let's look at the different levels of moisture. A dry wound. This is not conducive to healing. Never let the wound dry out in the air. The standard treatment is to apply hydrogel under the dressing. Minimal exudate. You should see a moist wound bed with only a light stain on the dressing. This is ideal for the wound. The standard treatment is to use a regular dressing like gauze. Moderate exudate. The wound bed will be glistening. You'll see visible staining on 25% to 75% of the dressing, but it won't be fully saturated. Here, you'll need a more absorbent dressing. Standard treatments call for foam, alginate, or hydrocolloid dressings. You can also start to think about active treatment at this stage, which would be negative pressure wound therapy, NPWT. Then there's heavy exudate. This will be pooling with fluid reaching to the borders of the wound bed and potentially running over. More than 75% of the dressing will be stained. At this stage, you definitely want to switch over to the active therapy, NPWT. It's worth us exploring NPWT further, and more specifically the PICO version of NPWT, since it gives you many other benefits when dealing with a non-healing wound. First, NPWT dressings create an airtight seal around the wound, which protects it from foreign bacteria. It also utilizes a pump that actively removes excess exudate from the wound, decreasing its inflammatory effects and lowering the chances of macerating peri-wound skin. Also, the applied compressive force has a therapeutic effect in and of itself, improving local blood flow, allowing a better delivery of oxygen and nutrients to the tissues. The pressure also mechanically pulls the edges together and pulls up on the wound bed. This encourages cellular epithelialization and granulation. And if you're using the Pico version of NPWT, it utilizes a special wound pad that does this more effectively and even extends that zone of therapy. The E of timers stands for edge. Here we want to inspect the edges of the wound and the peri-wound skin around the wound. You'll want to see healthy new epithelial skin migrating across the wound bed. As we mentioned before, the wound should shrink by about 40% over 4 weeks. A few things to look out for concerning the wound edges are rolled edges, calluses near the wound, tunneling, and undermining. And for the peri-wound skin, you should see smooth, moist skin with a consistent color. You don't want to see dry or cracked skin, maceration, pale skin due to reduced blood flow, or discolored skin due to venous leakage. Standard treatments include debriding rolled edges and calluses, packing dead spaces in instances like tunneling and undermining, as these have to heal from the bottom up, adopting a good skincare regime that includes cleansers, moisturizers, and barrier creams or films, control of excess fluid, and for fragile skin, avoid using harsh soaps and use silicone adhesives instead of harsher ones, as these can tear skin. For active treatments, consider skin grafts, skin flaps, or skin substitutes. And if you need to refer your patient, consider a plastic surgeon to employ the active treatments mentioned before, or consider a dermatologist for fragile peri-wound skin. The R in timers stands for repair and regeneration. This step is all about optimizing wound healing with active treatments and addressing factors that might be slowing down or preventing healing. Start by looking at the entire trajectory up until this point. Is standard wound care failing to heal the wound? Have you identified and addressed all risk factors for non-healing? Examine comorbidities that influence wound healing, such as vascular disease, diabetes, or malnutrition. And use an assessment tool like Bates-Jensen to systematically evaluate the wound's progress. Here, we'll only look at active treatments designed to stimulate healing. Some options are negative pressure wound therapy, to reduce edema, promote perfusion, and stimulate tissue formation. Topical growth factors, to stimulate cell proliferation and collagen production. Electrical stimulation, to enhance blood flow and cell activity. Low-level laser therapy to stimulate cellular activity. Skin grafts, flaps, and skin substitutes to rebuild non-existent or severely damaged wound beds. Stem cells to enhance regeneration and reduce chronic inflammation. And hyperbaric or topical oxygen therapy to deliver high oxygen concentrations to promote healing. And when you're thinking of referrals that can best help you in repair and regeneration, consider vascular specialists when dealing with CVI, PAD, and diabetic ulcers, as revascularization may be needed to heal the wound. Or a wound specialist. If the wound is stalled or complex, they can help guide treatment and ensure all factors are considered. And lastly, the S in timers stands for social factors. Now we'll look outside the patient to see if their social environment is hampering healing. These can be grouped into 4 categories: psychosocial factors, adherence factors, physical and comorbidity factors, and extrinsic factors. First, look at psychosocial factors. What is their cognitive state like? Do they have close relationships with family, friends, and community members who they can rely on for help? And who and what can they rely on for emotional support? Next, what is their capacity to adhere to the care plan? Are they health literate? Do they understand why they are doing the things you're asking them to do? And do they speak the same language as their caregiver? And can they read instructional materials? What physical and comorbidity related factors are involved? Are they mobile? And how will their comorbidities complicate the treatment in other physical ways? For example, how might neuropathy hamper their ability to notice repeated trauma? Or how might obesity limit their flexibility and their ability to reach certain areas? Lastly, look at extrinsic factors. Do they have local access to care? Do they have transportation to that care? And how far away do they live? And what is the current availability of caregivers in their area? Are their finances able to cover the treatment, and do they have insurance coverage? What is their home environment like? Is it hygienic? Is it safe? Addressing these issues is key, as even the most advanced treatments can fail if social determinants are overlooked. Collaborate with the patient, caregivers, and their community to overcome these barriers to care. So let's wrap up by looking at some big takeaways from this course. 1. You can identify a non-healing wound as a wound that fails to proceed through an orderly and timely process. 2. Early identification and treatment are key, as the longer you wait, the harder it will be to heal. 3. Use the Timer's assessment tool to aid you in determining your treatment plan. 4. Debridement is key in reducing inflammation, disrupting biofilm, and returning the wound bed to a state that is more like an acute wound. 5. When standard treatments are not working, escalate care to active therapies that can stimulate healing or refer them to a specialist. 6. And work to solve social factors that may hinder your treatment efforts. This wraps up our Smith+Nephew presentation on chronic and non-healing wounds. Today, we looked at what chronic and non-healing wounds are, why some fail to heal as expected, and how to properly assess and treat them using current best practices. I hope this will guide you in creating better outcomes and a better quality of life for your patients. And make sure to check out our other titles on Smith+Nephew Academy Online. Thanks for watching.